Good afternoon, everyone, and thank you for attending today's webinar, Telemedicine and COVID-19, Take Care of Your Patients While Allowing Them to Stay at Home, presented by Nancy Enos with Enos Medical Coding. Please be aware that there will be a question and answer portion at the end of today's webinar. Please type your questions in the question box located on the right of your screen, and they will be answered in the order received. Additionally, if you would like a copy of the presentation slides, you can find them in the handouts section on the right of your screen. They will also be emailed to all participants following the completion of today's webinar, as well as a recorded version will be available on the website for members only. Again, we would like to thank you all for attending, and I will now turn things over to you, Nancy.
Thank you very much. Hello, everybody, and happy first day of spring. It certainly is a very different time in our country, and I'm happy to be joining you to work together to understand how you can take care of your patients and allow them to stay at home. For the last week, part of the week, since Tuesday, I've been in really close contact with my colleagues in the MGMA Government Affairs Office in Washington. Claire and I speak very often on coding issues as I'm a MGMA consultant. And the information in this does not guarantee payment, but let me tell you that if you knew a lot about telemedicine up until Monday, or even a little, you need to put all that you knew into a box and put it on the shelf, because what I'm going to tell you, these new rules will contradict everything that you knew about telemedicine coding, and I don't want to cause any confusion. We have new rules to live under and work under for the time being, and we need to understand that. The payers, not only CMS, have been working on their policies, and I'm seeing a lot of payers are pushing their policies out. Pay close attention to them, because not everybody is going to follow the exact guidance from CMS. So we need to pay attention to who the patient's insurance is, and some payers, for example, will pay for a telephone call, but only a level 99211 or 212. And here I am telling you that you can bill any level of service. So understand the difference between CMS, CPT, and your payer contracts. Also, state laws vary based on recognition of licensed clinicians. So know who in your practice is a qualified healthcare provider according to state law, scope of practice, and credentialing with payers. That being said, let's go right into the presentation. And I look forward to seeing you when we get to reschedule the annual conference as well in person. But for now, let's work on what we know to be the new normal as of March 17th, 2020, when CMS clarified the guidance for HHS Secretary Azar, who put waivers on a lot of the telemedicine restrictions that will increase access for Medicare beneficiaries to stay home and receive care from your practice. Now, these rules are going to be retroactive to any telephone calls or telemedicine services that you provided to your patients back to March 6th, as long as they met medical necessity and documentation guidelines according to the information I'm going to teach you now. So remember to go backwards if you can and capture some of those visits, because we're all concerned about revenue being impacted while patients are canceling their appointments and not coming into your offices. The first restriction that has been lifted is the geographic restriction. So these telehealth services are not limited to rural areas any longer. Under the present time, the patient can be in any geographic locality. The patient does not need to be in any qualified site of service either. So the physician's office or healthcare facility has been removed. The patients can actually have this interaction with your providers from their homes or actually any setting of care at all. The type of technology used for the communication has also been lifted. So what they're saying now is any non-public facing remote communication product, that includes iPhones, as long as they have both audio and video capabilities. So the patient on one end of the call must also have audio and video, as well as the provider making the call has audio and video. So now face-to-face time in the office has been replaced with FaceTime. Without any video, you cannot apply these waivers, so you have to use the telephone calls and the CPT, and I have them in the upcoming slides as well. So that's a really important point to make sure that it's not responding to an email or communication through the portal, but it really is pertaining to E&M codes that can be used when you have both audio and video. It has to be interactive, real-time audio as well between the patient in the office at home and the provider in the office. So it's going to be things that are not public facing. And actually in the Health and Human Service notice on Tuesday, they specifically said that Facebook Live, Twitch, TikTok, and other modalities that I'm too old to understand are public facing, and they're not allowed. They should not be used in the provision of telehealth by covered health providers. Although there is broad relaxation of the HIPAA rules, don't take it too far. The Office of Civil Rights will take discretion, and they will not be imposing penalties for noncompliance with the HIPAA rules. So that is good, because I've had questions about patients signing waivers before receiving telehealth services, and that is no longer required temporarily under these new provisions. The HHS Health Information Privacy Notice that was released on Tuesday is in my handout. The COVID-19 FAQ sheet has a number of links, and you can pass this on to your privacy and HIPAA office. During the COVID-19 emergency, the HIPAA rules that usually prohibit some of these communications are going to be relaxed. So you don't have to worry too much, but you might be in a larger environment where your security office or your hospital will still have some restrictions, and they might want to seek additional privacy protection for using telehealth for their providers. So while the law may allow it, your organization may not. And in that case, I would recommend that you work with some kind of a vendor that's HIPAA compliant that can give you a more secure telemedicine platform, and will enter into a HIPAA business associate agreement with you. And HHS has given a number of examples, such as Skype for Business, UpDocs, VC, Zoom for Healthcare, DoxyMe, Google G Suite, Google Hangouts, Meetings, and so forth. Now, the providers who are eligible to engage in these telemedicine visits are the doctors, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetists, clinical psychologists, which is good because this extends to behavioral health as well, and licensed clinical social workers, registered dietitians and nutrition professionals, so education can continue through this modality as well. As long as you know what your state restrictions are in terms of scope of practice, licensure, and credentialing with the insurance carriers. I'll also add here that I don't give legal advice, and for the larger the organization, the more careful they're probably going to be with implementing this new service line, and you want to get the approval of your legal advisors and attorneys, as well as running this by your malpractice carrier to make sure that there's no restrictions on your practice. I'm giving information that is related to coding and billing only, so make sure you check all your check boxes before you go live with this. Let's talk about the codes that are covered. Reimbursement will be allowed for any telehealth covered CPT code, and I have an Excel spreadsheet that I can also provide as an attachment. There are 101 CPT codes that are designated as eligible for telehealth payment, and they can be used even if the reason for the visit is not related to COVID-19. This is for keeping your patients at home no matter what their diagnosis is. The types of codes that you can bill for services rendered remotely are office and outpatient visits, subsequent hospital nursing facility visits, psychotherapy, health and behavioral assessments and interventions, and ESRD services for managing the patient's labs. Medicare telehealth services are generally going to be billed now for the time being as if the visit had been furnished in person. The difference is now you're going to use the 99213, for example, on your claim. You don't need a modifier on that. According to Medicare, you may have different payers asking for modifiers. The thing that Medicare is going to look at is the place of service is not going to be 11 for the office. It's going to be 02 for telehealth. So be very careful when you're creating these claims not to use your office as the place of service, but 02 is the telehealth place of service. The reimbursement amount is going to be the same for your E&M codes as it would have been if the patient came to your office and was seen in person. So that's the reason that we're trying to get this information out to you very, very quickly, is that the telehealth codes that are available that you still can use reimburse much less than your office visit codes. So this is a great alternative. You should consider implementing these codes. Patients who have appointments who are now canceling, or you're canceling your office hours, that could be a huge decrease in reimbursement. But if you can see those patients and take care of their needs remotely, that could actually optimize your reimbursement in these very trying times. For services that have a different rate in the facility versus non-facility, the Medicare fee schedule will be paying the facility payment rate for the telehealth communication. It might be a little difficult to operationalize collecting a copay when the patient's not in front of you at your front desk. So for that reason, HHS is giving you the option. They will allow providers without any penalty to reduce or waive the cost sharing. So that could be the deductible or the copay during this time. They're providing this flexibility so that you can quickly operationalize this telemedicine service without any restrictions. They're not saying that you cannot collect a copay. You certainly can opt to collect it the next time the patient comes into your office, or if you have some way of having the patient call in with their credit card and collecting it remotely, or even billing the patient for it afterwards, you have the option to doing that, but you're no longer required. It's not going to be a compliance issue in waiving the copay due to this problem. Another restriction that's been lifted is the patient status. Traditionally, the telemedicine rules applied to new established patients and were prohibited for new patients. As of Tuesday, the new rules do not enforce that the patient be established or have seen the provider within the last 3 years. From a coding and documentation standpoint, however, it does seem to me that it's difficult to document a SOAP note with all 3 elements being required to support the level of service, because the middle element of exam can't be accomplished remotely more than the visual of the patient's general appearance. But for those visits for new patients, if you do perform them, documentation to support the level of service should be based on time, and time should be documented on all of these services as a backup. In addition to the evaluation and management codes, if you have some circumstances that don't meet the criteria, there are some codes that were implemented last year in 2019 for virtual check-ins and e-visits. The virtual check-ins are short patient-initiated communications, so the patient does have to be the one to contact you with a question. Typically, we see that through a portal or email that's secure. And Medicare also pays for the e-visits, which are the non-face-to-face initiated portal communication back and forth. And the codes for those 2 services and the description of them is listed right here. The difference between the 2, virtual check-in is for paying professionals for a brief 5 to 10 minute communication that might eliminate the need for an in-person visit, which is what this is all about, whereas a visit furnished via Medicare telehealth is treated the same as an in-person visit and can be billed using the code for that service using the place of service 02 to indicate the service was performed via telehealth. An e-visit is when the beneficiary communicates with their doctors through the online patient portal. And this is a snapshot from the Medicare website, what the type of service is for Medicare telehealth, virtual check-in, and e-visits. The description of those services, the HIP HCPC and CPT codes, and the restrictions based on the provider. A little bit more about the e-visits. Clinicians who may not independently bill for evaluation and management visits, for example, physical therapists, occupational therapists, speech language pathologists, clinical psychologists, can also provide these e-visits and bill with the G2061, 2062, and 2063. And those are going to be for cumulative time over a period of 7 days. And there are time thresholds of 5 to 10 minutes, 11 to 20 minutes, and 21 minutes or more. So those are for, billing no more frequently than once a week. Without using a portal, without having audio and video on a call, having the physician just call on the good old telephone, you still can report the telephone calls 99441, 99442, and 99443. The reimbursement, of course, is going to depend on who the patient's insurance payer is, and the amount of time should be documented in the record, as well as a summary of the discussion. This subcategory of codes is when the call is made personally by a physician, and the next range of codes is for non-physicians making the phone call, with the codes being 989, 66, 67, and 68, again, based on the threshold of 5 up to 30 minutes. Choose the code that meets the criteria and summarize the discussion. The majority of us would probably be billing for the physician calling the patient using the audio and video option, as long as the patient has that as well, and providing this visit remotely. If they do that and they bill, let's say, a 99213 just for the purpose of illustration during this conversation, they have to have a SOAP note that supports a 99213. So the documentation guidelines say that 2 out of the 3 components, history, exam, and medical decision making, have to be in a note. So your EMR template for telephone calls is not the right place to store these. It really should be an encounter where you're opening up an office visit template with a header that says this visit was performed remotely with the physician and patient using audio and video. That being said, you can go along and document either the elements of the SOAP note or the total time and choose a level for your code. Bill that code without a modifier unless the payer tells you to. And remember that the place of service code is changing to 02. The SOAP note has to have enough to support medical necessity for the service, first and foremost, and then the extent of the service to support the level that you've chosen. The history and assessment and plan are really going to be very important. Thorough documentation here will be brief, 1 to 3 elements will support a 99213, and extended 4 elements or more will support a 994 or 5. So the reason for the conversation, what is the patient's complaint, and what are they explaining this to the practitioner as far as how long it's been going on, the frequency, the severity, associated signs and symptoms, and so forth. Same as we see in the office visit, but now for this telephone call, you have to have an HPI, and then you also have to continue that with an appropriate review of systems based on what is supported medical by the HPI as far as medical necessity. So what I mean by that is you can't have a 14 system review of system checklist completed every time when the patient calls about a hangnail. It has to be what systems are affected by the chief complaint. That is a valid medically necessary review of systems. And there are 4 levels of review of systems, so you don't need any for 99212. You need 1 system reviewed for the 99213, and that's usually pertinent to the problem. A detailed 99214 requires a 2nd system, and that's usually a system that is associated with the problem. And then for the level 5 or your new patients, you need to have that complete 10 system reviewed. But be careful not to rely too heavily on templates as you're filling this out. The patient's past history might be discussed, especially if the patient is on medication or has chronic illnesses. The family history, especially if there's any chronic diseases or anything that runs in the family that is related to the chief complaint, and social history, social factors, lifestyle, and very important these days, exposure to others who are ill would be part of the social history, and that should be recorded as is discussed by your provider with the patient during this audio video call. So you should have enough documented in this remote visit to give you the level of history based on the most that is documented, the least that is documented in HPI, ROS, and PFSH. So the row across that has the least documentation is going to be your level. So expanded problem focused right in the middle is going to support 99213. Detailed will support 99214. We won't have much for the physical exam unless the doctor makes a comment about the patient's general appearance. Because it's a video, they might be able to see some things such as skin or capillary refill if they tell the patient to, press on their fingertips or something like that. But I imagine it would be very limited. The assessment and plan, the doctor should not copy down previous diagnoses from the problem list that weren't discussed during this visit or considered in the medical decision making, but the assessment should be a straightforward list of the diagnoses or symptomatic complaints that the patient has, the data reviewed, whether it's test results reviewed or the decision to order further tests, and the treatment plan based on what the risk is of complications to the patient. And the way we score this is taking these three factors and then calculating them all together. So I'll move through this and I'll show you a chart. Makes it a little bit easier to follow. Medical decision-making scoring, the number of diagnoses is 1 for each minor problem or stable problem, 2 points for a problem the patient's calling about that's worsening, 3 points for a new problem, and 4 points if that new problem has further workup planned. The data points are given by category, 1 for labs, 1 for radiology, 1 for medicine, 1 for reviewing history and old records, and 2 for the physician viewing images, tracing, and specimens. And the last element of MDM is the presenting problems. There is a column that's missing here. We don't use it very often. So the presenting problems and management options are the most straightforward to understand. Low risk 99213 usually have a stable chronic illness or an uncomplicated acute illness such as cystitis, rhinitis, sprains, viral illnesses that are minor injuries, things of that nature. And the remedies for those are usually over-the-counter drugs, physical therapy. Moderate, that supports the 99214, could be 2 or more stable chronic illnesses, an undiagnosed new problem with an uncertain prognosis for the workup is planned, an acute illness with systemic symptoms, especially in a patient who has underlying chronic conditions and comorbidities. And treatment options for that patient might include prescription drugs or IV fluids with additives. The level 5, is going to be chronic illnesses with severe exacerbation, life-threatening things that might actually send the patients to the hospital. I wouldn't really expect to see that in the office phone calls very often. And we put this all together by looking at the number of points for diagnoses, the number of points for data, and the level from the table of risk. And 2 out of 3 are required to support the complexity of medical decision making. So 99212 requires straightforward, 99213 requires low complexity, 99214 requires moderate complexity, and 99215 requires high complexity. The time rule, we don't really need to worry about the 50% rule at this point in time. Now face-to-face time is going to mean FaceTime. So you definitely should be writing down the amount of time spent on these calls. And just a reminder that all of these rules are going to change. We'll be getting some education on that in the fall and at our annual conferences when they occur, because January 1st, we're going to have some further tweaking of the MDM calculation and the time calculation. But for now, the existing table is going to suffice, and the left-hand white boxes tell us how to calculate the level of documentation in the SOAP note, if you're going to be basing it on that. And time in the right blue column is listed here for your new and established patient visits. And this should be a good reference for those office visits that are being provided virtually. And I can't stress enough that if you compare the telehealth codes to the office visit codes and realize the office visit reimbursement is higher, that adopting this whole opportunity to care for your patients remotely will be very important to your practice at this time. CMS is not requiring the use of the existing telehealth modifiers, and they're not going to be coming up with any additional ones. So this, we can just put in that shoebox on the shelf until we get back to normal billing after this event is over. But some insurance companies, I got this snippet from Mass Blue Cross actually, some payers are requiring modifiers. So if they are, the GT is going to be interactive audio and video telecommunication systems. 95 is synchronous telemedicine service via real-time interactive audio and video. So that would be if you're using a platform. So follow the payer's instructions in addition to what information you're getting from me today. State Medicaid programs also have the flexibility to cover telehealth, and they come up with their own policies. They will be paying at the same rate that the state is now paying for their face-to-face services. So check with those payers and Medicare administrators at the state level as well. So we've talked about the who can provide the service, where it can be provided with the place of service code 02, the CPT codes, and then the diagnosis code is going to be the last piece of the puzzle to put together your claim. And the diagnoses should be the reason that the patient needed the call with the provider. It might be their chronic conditions. That's easy to know what the diagnosis coding is for that. But if patients who call for symptoms, then report the symptom codes for cough, fever, and so forth. There is no restriction right now on what diagnoses codes will be considered for reimbursement for telehealth. So these calls do not need to be related to COVID-19. It can be related to the patient's high blood pressure. The means is just to keep them at home and talk them through it to encourage social distancing, keep the vulnerable beneficiaries from entering the healthcare facilities. So if they need a refill on their blood pressure medication, by all means, I-10 is a covered diagnosis code for that encounter. On January 30th, the World Health Organization did come up with a new diagnosis code of U07.1 for a COVID-19, and that is test confirmed. However, it's not effective until October 1st, 2020. So we don't have a positive COVID-19 diagnosis code that we can use currently. You're still going to have to use the signs and symptoms of respiratory failure, respiratory distress, and fever, and so forth. If the patients come to you because they want a test, the screening codes of Z71.84 is for a patient whose concern is related to recent travel, and Z71.1 is a person with feared health complaint in whom no diagnosis is made. So that's the person who wants a test, but they are asymptomatic. We used to refer to that as the worried well, but these days that takes on a whole new meaning. So just to recap some of this, the new rules will be in effect for services going backwards to March 6th, and they will continue for the duration of the COVID-19 public health emergency. Medicare will make payments for Medicare telehealth services to furnish to patients under border circumstances. These visits are considered the same as inpatient visits and are paid at the same rate as regular inpatient visits, in-person visits. Starting March 6th for the duration, Medicare will make payment for professional services in all areas of the country, in all settings. While patients generally have to travel to originating sites to have telehealth services, now they can stay in their home. Medicare copays, coinsurance, and deductibles generally apply to these office visit codes, but HHS is offering the flexibility. It is the provider's option whether they are able to collect the copay or reduce the copay or waive it entirely for these remote visits for the duration of this crisis. To the extent that the 1135 waiver, that's the legislation that was just passed last week, requires an established relationship, HHS is not going to be auditing claims to ensure that the patient was seen in the last 3 years. So you don't need to worry about that measure either. The rest of the slides are here for your reference because, as I said in the beginning, some of you might know a little about telemedicine and want to know about the other codes. So I left them there for a reference, but I won't go over them because they really could cause a lot of confusion. I'll refer to them only if there's specific questions about what the other telehealth codes are. But for right now, we really have to look at using the E&M codes and the 101 covered codes. And I only use the SOAP note and the E&M type of documentation requirements. But remember, if it's a behavioral health counseling type of visit, they should also rely on the templates and the documentation requirements that meet the CPT codes that they generally use for the care that they are giving their patients. As long as it's medically necessary, it's documented, and you're using the appropriate level of service code, then you can bill for these services as they were provided in person. And with that, I think we're ready to open it up for questions and answers.
Thank you so much, Nancy. So we do have a ton of questions in here.
Okay.
The number one asked question was, are you going to be able to share the entire presentation slides with us so I can send those out? Right now, we just have the fact sheet.
Yes, I will. It was
perfect.
so dynamic. It was changing hourly, so I wanted to make sure that we released the latest version that we could. I'll send it right along.
No problem. Thank you. So we'll get started with the first question. It is, what if a patient does not have access to any type of video conference? Can we bill for a phone call in these situations?
Yes, that's all you really can do. If they don't have a neighbor, a grandchild, whatever, who does have a smartphone, then it would not qualify. Use the telephone calls, the telephone codes.
Thank you. The next question is, place of service code for code G2012, brief communication technology based would be 02, correct?
Yes, that's correct.
Next question, I am being told by my billing company to use modifier GT for Medicare patients. Is this correct?
That's incorrect as of Tuesday, March 17th. Medicare is not requiring any modifier. And there's a link to that legislation that is in the FAQ sheet.
Thank you. I work in pediatrics. Are we allowed during this time to provide virtual well visits?
No, the well visits are not on the list. The well visits require a physical exam component. It would be impossible to achieve that physical exam component. I would think that the 99401 type of codes where you're doing the counseling for preventative care without the physical exam component of it would be more appropriate.
Okay, can my RD use and bill via telemedicine? She's credentialed and bills face-to-face.
Yes, dietitians are listed as part of the qualified providers.
Is there a requirement on the location for the physician providing the service?
No, there is not.
Okay. We are also being told no referral, off copay, coinsurance is needed. Also, new patients can have telehealth.
New patients can have telehealth, and the requirements for authorization depend on the HMO that the patient is enrolled in. So definitely check with the payers and those plans that are HMO that require authorizations. Check in with them and make sure that they're going to be waiving authorizations during this period of time. That would be payer specific.
Can you speak to RHC and FQHC? Has this waived the face-to-face requirement and restriction of being a delivery site?
I'm really sorry, but I asked that question on Tuesday to the MGMA Government Affairs Office in Washington. They didn't know, and they're trying to get me an answer, and we haven't clarified that yet. It's confusing because, yes, they bill E&M codes, but they get reimbursed an encounter rate. So that is not clear, and I'm going to try to get that answer for you and send it out, but right now I don't know.
Okay, National MGMA says Facebook is okay. Are you saying it is not?
Facebook is not okay, and it is specified in the regulations that came out by the HHS and OCR. The link to that is in the fact sheet as well.
Okay.
Facebook Live was definitely mentioned as something that was not allowed.
OT and PT cannot do telehealth visits yet, right?
We had a slide a little bit back about what codes they can use. Yes, they can do face-to-face visits. I'm just jumping back really quickly to get to that slide. It's before my E&M. Yes, clinicians who may not independently bill for E&M evaluation management, like physical therapists, occupational therapists, can use the G2061, G2062, G2063.
Thank you. Is waiving the copay only for Medicare? What about commercial payers?
I would check with the commercial payers on that. It's usually the federal government that we base our compliance rules on, but that would be a payer by payer specific.
Okay, NGS says POS 11 for G2012 and G2010 and e-visits. Not sure what that question was.
NGS.
What are the documentation?
POS 11.
Okay. What are the documentation requirements for the virtual check-in visits?
A type summary of what was discussed and the time.
Okay. Would you recommend that the video method of communication, an example, FaceTime, be documented in the progress note?
Yes, definitely. I would put that, right at the top of the note or right at the bottom of the note. It should be clear that this was not an in-person visit.
Can we bill a 99213 for a telephone-only visit?
No, you have to have video.
Are NP/PA able to bill the 99441-99443?
Let me get back to that slide. They're not physicians. There are two different codes, one for physician and one's non-physicians. 441 is for a physician or other qualified healthcare professional. So that would be a PA or an NP, yes.
Okay. Are G codes only for Medicare or can we use for all payers?
G codes are promulgated by Medicare, but other payers frequently adopt them. So I would check with your payer contracts.
Okay, the next question is, so 99201-99215 cannot just be a phone call, correct?
Correct. There must be video.
And for 99441-99443 are for phone calls with no video, but they are subject to no prior 7-day EM or visit within 24 hours.
That's correct.
And 99201-99215 can be phone with FaceTime.
Yes.
Okay. Are telephone services for behavioral health therapy sessions covered without any video component?
The telephone codes 98966, 9896768, yes, that would be okay. But the actual behavioral health codes that would be used for in-person can only be billed with audio and video.
Can nurses perform telehealth?
No.
Okay. Difference
They can
between
use the,
G, sorry.
outside, the nurse can use the 98966 because they're a non-physician, but nothing else.
Okay. What is the difference between G2012 and 99441? What equipment is used for G2012?
G2012 is usually a portal and 441 is a telephone. So one's online and one's on the phone. That's the difference.
Thank you. When would a provider use the virtual check-in call versus 99441-99443? Is it basically the same? Is it basically the time involved?
No, it's the modality involved, whether it's a phone call or responding to an email or portal question.
Can anyone have telehealth? If young or healthy people want telehealth, can we bill it? Can we bill for it and be paid?
The reason that the government implemented this so quickly is because we're encouraging social distancing. It doesn't matter if the person is young or old or healthy or sick. Everyone needs to start staying home. So there are no restrictions on who the patient is.
If doing a new patient consultation by telephone only, do you still use codes 99441, 99442, and 443?
Yes.
How can we bill E&M codes without vital signs?
If it's an established patient, you have the history and the medical decision-making to support your two required components to support the level of service or time to support the conversation and content of the visit. Vital signs are not necessarily a required component of every E&M visit. From a documentation and billing perspective, it might be from your standard of care when patients visit your office, but it's not required for billing.
What codes should a LCSW use for phone visits or telehealth visits?
Again, they can use the 98966, 67, and 68 if it's telephone only, and they are a qualified non-physician.
I know that you do not intend to give legal advice, but is there a need for a separate consent, even if verbal and documented, for telehealth E&M services? I know it is required for G2012.
I'm not a lawyer, so I don't answer legal questions, but if you read through the links in my fact sheet, it will bring you to the OCR rules that are giving waivers for consents.
Do 99441-99443 require the GT modifier, and if audio and FaceTime for 99201-99215 require a GT modifier?
As of Tuesday, Medicare is not requiring any modifier. Check with your various payers for their requirements.
A recent webinar indicated U07.1 may move up to April 1st, 2020. Is this correct?
I have not heard that yet. I'm anxiously awaiting to hear.
Sure. Can the 99441-442-443 codes be used for phone only, no video?
Yes.
And what about the 99212-3-4-5 codes?
No, they must have audio and video.
Thank you. I was told that for telephone calls with no video, we could only bill G0212. Is this true?
That would be if it's through the portal, but not if it's over the telephone. The telephone, I would lead you to the telephone codes 99441 through 99443.
Thank you. What about losing the licensing restrictions across state lines for MDs? Can practice in one state but licensed in another?
I did read that myself recently. They're relaxing those regulations because of the shortage of physicians during this crisis, but I would urge physicians to check with the Department of Health in each state.
Are specialty services like addiction medication providers able to do telehealth visits?
It depends on the level of licensure and the scope of their practice and their credentialing with the payers. They're not prohibited. They just need to make sure that they're allowed to bill.
Can 99441-443 be billed to Medicare?
I don't see them on the list of telehealth, but they're not telehealth codes, they're regular codes. I would have to check the Medicare fee schedule, and you know what, I'll check the Medicare fee schedule and add a comment to this slide and find out if Medicare pays them. Of course, as a documentation and coding expert, I don't usually get into billing. It's a little bit of a theory versus reality. I'll check on it.
What were the FaceTime codes?
All the E&M codes.
Okay. If it is phone only, can we use virtual check-in or 441?
You can use virtual check-in if you're using a portal, and you can use 441 if you're using the telephone.
Does Medicaid need both 02 POS and MOD 95?
Check with the bulletins that have come out from the various Medicaid agencies and find out what their instructions are. That's going to vary by state.
If our nurse does a telehealth call with a patient, can we bill a 99211 for her?
The physician's not required, so it seems like it's the same as an in-person visit. There's no reason that they shouldn't. That's going to be dependent on the payer, but I think that there are some payers who are saying bill 99211s and 212s exclusively. I would check with each payer to confirm that, but from my coding perspective, I would say yes.
Can you contrast a normal phone triage versus physician telephone services 99441, meaning if physician calls back, is it now billable?
If the call goes from a triage to actually evaluating and managing the problem, then yes.
PA and NP can bill 99441 and do not use the 98966?
They would be qualified healthcare professionals, yes.
Okay, 98966, is that used via LICSW?
Yes.
Can we use the 98966-98968 codes to bill for group therapy sessions?
How many? You'd have multiple patients on the telephone call. If you could do that with video capability like a Zoom meeting, you would bill the normal group therapy codes.
Okay, can medical assistants use 98966?
No, a medical assistant is not a healthcare professional in terms of being qualified and licensed.
For virtual check-in visits, what is the reimbursement?
I have a reimbursement sheet that I will send out as an attachment.
Thank you. If patient calls with personal concerns about their COVID-19 risk factors, can medical staff bill for time? How about physician?
Depends on what the level of qualification is in the medical staff. The physician, yes.
CMS guidance clearly stated preventative screenings and visits are covered. Is this a private company or CMS contractor?
Can you read that again? You said CMS said it?
Yes, CMS guidance clearly stated preventative screenings and visits are covered. Is this a private company or CMS contractor?
If that guidance was from CMS, then it would be a CMS contractor. If you want me to look at that in writing, you could email it to me, just for clarification.
Thank you. All payers will pay the office visit codes 99213-99215 with telephone with video? Question mark.
Not all payers. I've heard that some payers are only paying level 1 and 2. So check with each individual payer's policy and proceed according to your contracts.
If a nurse practitioner was providing telehealth services for a birth control pill follow-up, what code would be used typically?
I'd have to look at the level of documentation. I would think that that would be the same as it would be in the office if the patient had come in for a birth control visit, a level 2 or level 3.
Thank you. Can you confirm a nurse can bill 98966-98968 with proper documentation?
If the person is licensed and a qualified non-physician, let me get some written guidance on that.
Sure.
That would be a registered nurse. I'll check on that and I'll add it to the FAQ sheet.
Thank you. Does telehealth include chronic care management?
Let me just take I have all the codes that are under the telehealth. There's 101 of them, so I don't have them memorized. I don't believe it is. I can actually pull that sheet up very quickly. It's right here.
Sure.
Transitional care management codes are covered, but not the chronic care management. I don't know if everybody can see that, the list that I just put up here.
We do not. I just see your desktop screen.
Oh, okay.
Okay.
Those chronic care are not covered.
Sure. For 99441-443 codes, can a physician bill for new patients?
Yes.
Can you bill a 99391-394 for telehealth?
391. The pediatric physical codes, no.
Okay. I thought G2012 was just a brief check-in call.
Okay, pull that up. G2010.
G261-G2063. Oh, I'm sorry, that was the second question.
Oh,
the one we're on is G2012. Is that just a brief check-in call?
Yes, brief 5 to 10 minutes is G2012. And the e-visits are the 99431 or G2061. Those are on slide 21.
Thank you. Can you provide documentation showing we can bill for CPT codes 99441-423? CMS told us that we were not on the covered code list. It would be great if they were covered, but I would like to see documentation stating we can bill those codes.
I don't know the context of that, who we are, what the provider type might be, but I will look into it. I already wrote down a question for those codes to verify that they're covered by Medicare.
Thank you. NGS says vitals can be self-reported. I think that was answering another person's question.
Right.
Can a nurse go ahead.
Patients can state what their weight is and temperature, but it's not going to affect the level of code, because if you only had the vitals as, you know, vitals and general appearance, that would still be 1 point for constitutional, and the weight of your E&M level would be resting on history and medical decision making.
Thank you. Can a nurse practitioner use G2012?
Yes, as long as they're credentialed with the patient's insurance payer.
If the patient was seen in the past 7 days and we are using phone only, what codes should we use?
I don't think it would qualify as a billable visit if it's in follow-up to a recent visit because of the restriction for the previous 7 days.
Thank you. What are the video conference codes for an LICSW?
It depends on the type of service the LICSW is providing. It would most likely be the behavioral health codes, which would be listed under the 90785, 90791, 92, 90832, 33, 34, 36, 37, all the way through 90847.
Thank you. Can you bill new patients without using video?
No.
Okay. Is there typically patient responsibility for 98966?
I would have to check on that. It depends on the payer.
Okay. Is a nurse practitioner considered a non-physician provider?
Yes.
And what codes could a nurse practitioner bill for telephone-only encounters?
Well, hold on one second. Let me just get there. The definition of the physician call says physician or other qualified healthcare professional, who does include PAs and nurse practitioners. So while PAs and nurse practitioners are not physicians, the definition of 99441 does include both physicians and other QHPs, such as NPs and PAs. So the 99441 to 99443 would be appropriate.
Thank you. Are you aware of any language put forth about the billing requirements for situations where synchronous video visit was initiated but not completed via video? Example, due to technical failure, visit then completed via telephone.
I'm not aware of anything that would allow you, such as a discontinued service modifier that we see in surgery. No, unfortunately.
Okay. Can care managers bill 98966 for COVID check-in calls?
Let me see. 98966.
Yes.
That's a qualified non-physician healthcare professional. So what was the question?
Can care managers bill 98966 for COVID check-in calls?
It depends on the licensure of who that care manager is. It could be a licensed nurse, then it would be yes. If it's someone of a lesser licensure, then no.
Thank you. The Medicare chart showed we can use a telephone for G2012. Is this correct?
Just get that up. G2012 is via telephone or other telecommunications device. Yes, the virtual check-in can be by phone.
Thank you. Where is documentation that FaceTime is acceptable?
There is a link in the FAQ sheet to the regulations by the OCR. The Office of Civil Rights is the body that oversees HIPAA privacy regulations.
Thank you. I understand that 99441-443 are the commercial phone visit codes, and G2012 is the telephone visit code to be used for Medicare. Is this correct?
Other payers might follow Medicare with the G codes as well, so check on it by payer by payer. However, that is generally correct.
Okay, someone just made a comment. Nancy, there are MDCR allowables for 99414 through 99443 in PA and NJ, just an FYI.
PA and NJ, thank you, appreciate that.
What are the portal codes and what are the requirements for levels of visits? But they did not specify.
Those would be the G codes for the telehealth. If it's through the portal, it wouldn't really be a visit. The e-visits through the portal are 99431, 99422, 99423, and then G2061, G2062, G2063. Those are all e-visits through the portal.
Thank you. Are telehealth services billable for specialties such as ortho and physiatry services? I apologize for the way I pronounce it.
Yes, definitely.
Thank you. Does the patient have to initiate the call in order to bill 99441?
Let me see.
Yeah. What's your last name, John?
The evaluation manager would have to be requested by the patient at some point, yes.
Okay. Does an RN bill 99211 or 98966?
It depends on the scope of the visit. There isn't any documentation requirement for 99211. It seems like in many instances, either would be appropriate. So compare the reimbursement, check with the reimbursement policies of the payer, and document it according to the code that you're choosing.
Thank you. Can an oncologist do a 6-month follow-up visit via phone and bill 441-443?
Yes.
Okay. G0402/G0438 and 439 can be used for annual visits conducted by telephone calls. Is this correct?
Yes.
Okay. Can all codes for telehealth be billed out on a UB instead of a HCFA?
If you're in a facility and that's what your contract is, check with your payer.
The 1135 waiver does not include the 99441-3. Can you confirm?
It's not specifically listed. Let me just double check that list again. 441. That's correct.
Thank you.
Other payers might allow it, not Medicare.
This is a follow-up to a previous question. If you had a group therapy session that was just over the phone with no video component, how would I bill for that?
There are no codes for group telephone codes. They would not be billable.
Thank you. What is the difference between the 98961-68 and the 99441-443?
The provider of service being a qualified non-physician healthcare professional, or the provider of service being a physician or other qualified healthcare professional.
Can we use these codes for evaluation of benign skin lesions?
There's no restriction on what the reason is for the visit. I can't give any clinical advice based on how you might view and evaluate a skin lesion, but from a billing perspective, if you take a history and make an assessment and plan, you could use the E&M codes for a remote visit. It's more of a clinical question, though. I'm not sure if it could actually be accomplished.
Do we tell patient phone call is billable, or do we ask their permission to proceed?
It's always good customer relations to advise them that they might have a bill or a copay, so that they're not surprised.
Okay. G2012 includes telephone. Doctors and certain practitioners may bill for these virtual check-in services furnished through several communication technology modalities, such as telephone.
Yes.
BCBS has sent out their new guidances, always is having a webinar. What other payers have sent out information regarding new telehealth guidances?
I don't work in a practice, so I don't know. It might be great for your listserv. I know Margaret Dalton in Massachusetts, Rhode Island has set up a listserv for people to share resources. That would be a wonderful way for everybody to put in all their payer information so that everybody knows what's going on payer by payer.
Thank you. Can you bill TCM through telehealth?
Yes, you can. The 99495 and 99496 are on the 101 list of covered telehealth CPT codes.
Can annual visits be conducted via telephone calls for Medicare patients?
Yes. There actually is no physical exam component of the documentation requirements for that visit, so it fits quite nicely into the remote model.
Okay, what about MAs? Would they be considered a qualified non-physician for telephone billing?
No.
Okay, can 99441-443 only be used on established patients?
There is no restriction.
Thank you. Can 99495 be billed as audio and visual as the face-to-face?
Okay. No, because that base code doesn't really require anything more than telephone communication with the patient. It's either direct contact telephone or electronic communication when the patient is home from the hospital. So you don't need video for 99495 or 99496.
Thank you. As a strategy, should we now market our services nationally as opposed to regionally in effort to get our provider schedules filled with televideo visits?
That's a clinical question, and the quality of care, given you don't know these patients and you can't do an exam, is something that your practice should consider very carefully, depending on your specialty. I would not give you advice on that.
Thank you. Can we bill for 9941441-43 and other telehealth codes if we bill as incident 2?
No, you'd have to use the correct code that identifies the level of physician or non-physician. So yes, if it's a 99441 for a NP or PA who bills incident 2, but not for a non-physician.
Does a telephone-only telehealth visit require a blood pressure?
No.
Okay, orthopedic physician has a video call with an EST PT and has MCR insurance. Are we able to use 99211-214 codes? If not, what are the G codes?
Is an orthopedic surgeon having an audio and video call with their patient or with the physical therapist or occupational therapist?
It says video call with EST space PT.
Okay, with the established patient. As long as they have a video telephone call, yes, they can bill the E&M codes.
And then it says, if a new patient, are we able to use 99202-204?
As long as time is documented, because you cannot complete the physical exam requirement.
Okay, is FaceTime okay for commercial carriers as Medicare is?
FaceTime has been approved by the Department of Health and Human Services. I hope that all payers will follow their lead, but you do need to check with payers that you're contracted with as far as their contracts that you're bound to follow.
G2012 through portal. Can you please explain and confirm not just physician making a phone call to the patient?
The brief 5 to 10 minute check-in is your practitioner with a telephone or other telecommunications device to decide whether an office visit is needed or a remote evaluation is needed. It is a remote evaluation of recorded videos or images that are submitted by an established patient. I need an example of why the physician would be calling the patient without the patient initiating it.
Okay, the next question is, I thought they waived the 7-day requirement.
I have not heard that myself. For the 99441, no.
Okay, what about
I'm not
home
sure
health
if-
agencies?
Oh, okay.
What codes can they bill with?
They have not been addressed as physicians or qualified healthcare providers who are impacted by this waiver.
Okay, did I hear you correct in stating that an annual health screening can be completed via telehealth services, telephone only?
Such as the Medicare annual wellness visit. I did not say telephone only, but it could be completed remotely with audio and video.
Thank you. For pediatric well care other than 99391-394, is there a HCPS that can be billed?
No.
Okay. Do teaching physician rules apply for residents involved in telehealth or virtual visit services?
I would look into the primary care exception. Otherwise, I don't think the criteria would be met.
Okay, what are the document requirements for an RN visit 99211 and 98966-68?
There are no specific documentation requirements, but a note about the encounter should suffice and show the reason for the visit and support the medical necessity for the visit, whether it's a question about medication or something minor.
Can you please clarify what place of service is used to bill G2012?
Now, I was hearing that NGS has on their website to use POS 11. That could be specific to national government services for Medicare in New England. The guidance that was just released under the waiver is saying that all telemedicine with these new rules can be reported with 02. So I would check with the payers to see if any other payers have the exception where they want 11. And I would also check to make sure that their place of service code 11 is ongoing, or if it's going to be overridden by the 02 based on this particular crisis due to COVID-19 that went into effect on March 17th. And some of the things that we know we're finding on their website might be their usual information, and then the Tuesday, March 17th information needs to be, filtered on top of that. So, check with the payers.
Okay. Orthopedic surgery practice here. I assume all post-operative global rules still apply, like no EM billable if related to the global issue?
Yes.
Okay. Where can we find the list of approved CPT codes for telehealth?
I will send it out.
Thank you. Is there any info about pediatric well care? I am only seeing and hearing well care for Medicare.
We've mentioned that several times, and the pediatric well care codes require a physical exam. I don't know how that could be accomplished with audio or video.
Okay, would a licensed dietitian in a diabetes practice be able to bill using 98966-8?
Just scoping through the list right now. I don't see that code on the allowed list, no.
Okay.
Medical nutrition therapy codes, I'm sorry, 97802, 03, and 04 are the 3 codes on the allowed list for a registered dietitian.
Thank you. If insurance company is supposed to bill for all visits without company redeductibles, why do we have to collect them and insurance not pay? Can patients get reimbursement for home BP cuffs?
That's a bit of a rhetorical question. I don't know what you mean by not paid unless someone's frustrated with their claims denials. All I can say is the new regulations will allow you to waive a copay if you don't have the means to collect it at this time.
Okay. Are all deductibles and copays waived for Medicare?
No. Providers have the flexibility to waive the copay if they don't have the means to collect the copay and they want to quickly operationalize this telemedicine in their offices. You can collect the copay at a future time. You can bill the patient. You can take credit cards over the phone, but you don't have to collect the copay at this time.
Thank you. Can 99201 through 215 be used for telehealth services provided by MD/DO/NP/PA?
Yes.
Thank you. We bill our NP and PAs as Incident 2 and they are not credentialed with Medicare. If the NPPA provides the video visit, can we bill 99201 through 15 incident to a physician in our practice?
The Incident 2 criteria has to be met, so I would think that the mid-level provider has to be an employee of the practice, that the supervising physician has to be immediately available in the office suite, and the patient has to have previously been seen by the physician for the same problem and is under a plan of care. So for follow-ups only, yes.
Thank you. Can physicians initiate the 99441-443 visits?
I'd have to understand why they would to support medical necessity. Usually it would be in response to a patient phone call.
Thank you. Did I hear you correct that the 7 days does still apply to any codes used for online EM codes?
I have not read any exception to the 7 days.
Thank you. Are there any restrictions for providing prescriptions for controlled substances?
You would check with your state Department of Health on that. I have not seen anything about that.
Thank you. What documentation is needed when LCSW providers telehealth or telephone visits?
They would write their note that they usually would for a behavioral health encounter and put a statement in that the visit was accomplished through means of audio and video on both the side of the provider and the patient.
Thank you. Can a child psychiatrist supervising psychiatric NP observe the visit by telehealth charge, and if so, what code?
Would the supervising and the rendering provider be together in the same location? That's very difficult to envision that scenario in the remote setting.
Sure, they had a second half to that question. It is suppose the psych NP is also doing telehealth at that time and not every visit. Can the psych NP do initial visit if from the pediatric practice do a new visit by telehealth?
New visits, Incident 2, cannot be done.
Okay. Can you please clarify if an RN can bill for a 98966-8?
Non-physician. I think we had that question earlier and I was going to verify it. Yes, 996. I already have that question written down and I'm going to verify it.
Thank you.
I believe so, but I want to check.
Are substance use disorder services such as group individuals and intensive outpatient service covered by telehealth, audio, and video?
Just taking a quick look down the codes. Yes, the GO445, GO446, GO447 codes are all covered. We'll be
Thank you.
providing the list of covered codes.
Great. If completing a female wellness exam through audio and video telehealth, what components of the physical exam would need to be documented?
I can imagine that that could be accomplished remotely because it is not based on any complaint that could be recorded in the history, and there's no medical decision making. The elements must be the physical exam. I would not recommend thinking about that code under the telehealth.
Okay. For G2012, do we need to document this as patient prompted?
Yes. And for any of these interactions, I would list who prompted it and what the means was, specifying the technology.
Okay. Can the physician use the telephone codes for patients that had scheduled visit and it is being done to protect the patient's health?
Medical necessity is always the key. That it was prompted by the patient, that we're keeping the patients out of the office because of the instructions by the government for social distancing. That's the reason for all of this, so that will be a given.
Okay. You mentioned that chronic care is not covered. Can you provide an example of what chronic would be from an ortho standpoint?
Typically, orthopedic surgeons don't care for chronic systemic diseases such as diabetes, congestive heart failure, obesity that is causing organ-related long-term chronic diseases. It doesn't pertain to chronic back pain.
Thank you. What is the difference between G2012, G2010, and 99441-443? Do we use the G0212 and 210 for Medicare only and use 99441-443 for commercial?
That's generally a good idea. The G codes are promulgated by Medicare for Medicare covered services, and the traditional CPT codes are more often recognized by the commercial. But again, make sure that the documentation matches the code description that you're going with.
If the patient had a follow-up visit that was canceled due to COVID and the physician calls them to do their visit over the phone only, can we bill in 99441-3? Can we assume the patient initiated the call as they had a visit? Do we need to document that the patient initiated the call?
Well, the patient made an appointment, and in lieu of fulfilling that appointment, you're using the telephone as your means, so that would be fine, and you could document it as such.
Okay. Do we need to document in our note that the patient did consent to the telehealth service, and do we have to note audio and visual by provider and patient in our note?
You definitely have to document audio and visual in the note. The patient consent has been waived under HIPAA per the OCR.
Okay. Can a CDE bill for telemedicine diabetic education?
The codes that are allowed for nutritionists are 97802, 97803, and 97804 for medical nutrition therapy only.
Can 99281-285 be coded for telehealth?
99281, let's see. Absolutely not. Emergency department visits have to be rendered in a hospital-based 24-hour emergency department.
Okay. Can 99281-285 be coded for telehealth?
Absolutely not. It's not occurring in the emergency department.
Okay. The next question is, I'm sorry, can you please repeat the answer for the chronic care from the ortho standpoint? My remote session timed out.
Chronic care codes pertain to chronic diseases that the patient has, and that would not be appropriate for complaints such as chronic pain. Chronic care management codes are usually for patients with systemic chronic diseases such as hypertension, diabetes, COPD, etc.
Thank you. And I do want to let everyone know we are going to be capping the questions at 1:30, so I will be wrapping this up with the last couple questions that we have in here. The next question is, follow-up question regarding SUD services. Can you confirm the code G0445 through 7 are specific to substance use? A quick lookup states differently. Thank you.
G0445.
G0445 through 7.
They all have different meanings. G0445 is semi-annual high-intensity behavioral counseling to prevent sexually transmitted infections. G0446 is intensive behavioral for cardiovascular disease, and G0447 is counseling for obesity. And I don't believe any of them. Oh, yes, they are. Yep, 0445, 446, 447. I'm sorry, they are on the list of approved telemedicine codes. We'll be emailing this list out, so you can check the list if you have any questions about which codes you can bill for telemedicine.
Thank you. Can Zoom be used for telehealth?
Yes, as long as it's private, not public facing, and it has an audio and video capability, that is allowed.
Is management of obesity and related chronic conditions / prescriptions refill covered?
Yes, as long as you're using the code that describes the extent of the service and it's documented.
Thank you. Can telemedicine be used within a facility? Patient outside and provider in urgent care interacts by telehealth to screen to patient prevents exposure.
As long as it's audio and video, yes. Not telephone only.
Can a PCP office bill for tobacco counseling via telehealth communication?
Yes, G0436 and G0437 are on the approved list of covered telehealth CPT codes.
Thank you. Can Skype Personal be used?
As long as it's not public facing, it's a private, secure audio and video, yes.
Okay. For our nurse practitioners, do we still need to use the SA modifier? Our EMR only allows one modifier to be attached to the level code. Should I use the modifier 95 or SA? For example, should we use 99213-SA or 99213-95?
Medicare does not require any modifier at all. The place of service code 02 will let them know that it was a remote visit, so you can continue to use the modifiers that you have been. However, check with payers on what their modifier instructions are.
Okay, so that was the last question we had for the day, so I'm glad we were able to get through them all. Thank you so much, Nancy, for doing this for us. We really appreciated it. And if nobody has any further questions, then we can wrap this up. Once again, Nancy will be providing the presentation slides, so they will be emailed to all participants and will be available on our website, as well as a recording of this entire webinar will be available as well. If anyone has any additional questions, please reach out to Nancy directly. I thank you all for attending, and I hope you all have a great day.
Thank you.